Yeah, we can start here. Sorry, there was some technical.
Okay. So, good evening, everybody, and welcome to the July webinar for on ophthalmic packages under PMJAY. And I would like to hand over this session to Dr. Raja Narayanan, who is the principal investigator for IHOPE, to take this forward. Dr. Raja.
Yeah, thanks, Arnaz. So it's my pleasure to introduce Dr. Sudha Chandrashekar, who is our guest speaker today in our monthly webinar. So many of you might be knowing Dr. Sudha Chandrashekar. She is the Executive Director at National Health Authority, Minister of Health and Family Welfare, Government of India. She did her MBBS and MD and also has done MPH and MPhil from UK. And she has more than 20 years of experience working in the field of academics, research, and administration. She is also a public health specialist and a pharmacoeconomist. And her passion for universal health coverage, health economics, and improving the health system overall in our country, I think is what has led her to take this line, and we are keen to learn from her and see how we can overall help her as well as NHA in improving the health systems of our country and also improving the overall health outcomes in our population. So over to you, Dr. Sudha, and thank you once again for joining us.
So good evening, everyone. I have Dr. Dhananjay also from my team who has joined the call. So today we will have some brief overview of the ophthalmology services under ABPMJAY, and then we can see how the key special features of our new packages and the health benefit packages that has been released recently. So we can understand that, and then we can have some discussion and open house. So that would be the format, and if we can have the questions at the end so that I can run through the presentation, which is a short one, and I've left more time for discussion so that we'll have more to hear from you also.
Sure, that's fine.
Yeah. So so we'll have overview, and I've just put in some numbers so to get some utilization and the key highlights and some recent developments. So when we look at the scheme as such, I'm sure everybody may be aware of what the scheme is and how that has been. It's been already 4 years now. We'll be soon celebrating the 4th anniversary of the ABPMJAY. Which was launched in 2018, which covers around 40% of the population in the bottom range, and with an entitled beneficiary getting a sum insured of rupees 5 lakh per family per year. So that, so it's a center and a state co-sponsored scheme with a 60-40 ratio. And in some states like the Northeast, we have a 90-10 ratio. And in some UTs, we have the 100%. It's a centrally funded scheme. And mostly the implementation, majority of the states are doing it on an assurance mode, but we still have some states implementing in the insurance mode and a hybrid mode. So that, they have also tried to integrate their existing state scheme, because some previously the scheme has replaced the RSBY scheme, which was nationally being implemented, whereas some states had also running their own state specific schemes. So in that sense, some of the schemes have been integrated along with ABPMJAY, whereas some states have still continued to implement their specific scheme. So the main key features is we are covering around 10.74 crore families, approximately 50 crore individuals, with 3 days of pre and 15 days of post-hospitalization expenses, assuring a sum of 5 lakh, covering 1670 procedures as of now. But when I go through the new packages, which has not yet gone live, it will be in a couple of weeks. in a week's time, or maybe in a couple of weeks, it will be live. So currently what we have is 1670 procedures. And the main USP of the scheme is the portability. So if a beneficiary can avail these services across the country, both in public and private facilities. So, but the main base database for this is the SECC database of 2011, but many states have gone beyond this. They have added more number of beneficiaries to expand these, and also covers already enrolled beneficiaries under RSBY beyond the SECC 2011 data, and specifically converging with more state implementation schemes, both in the insurance and the assurance mode. So some of the states, what we can say, still 3 states are not part of our scheme. That is Delhi, Odisha, and West Bengal. Whereas almost all the other states have implemented the scheme in different ways. Some have gone, as we said, a completely assurance way, wherein the government will be implementing the scheme directly through their state health agencies. Whereas some of the northeastern states have gone through the insurance mode, because they have found that as something that is more sustainable. Whereas some states are trying their implementation through a hybrid, that is till a particular sum insured level, it is assurance mode, but beyond that, it is insurance mode. So in that way, they are working out the, these are different models of implementation. So this is a very ophthalmology group. So I'm sure that based on the kind of burden that we currently have, so this scheme has a lot to offer to ensure that all these morbidity and the burden that many of our beneficiaries are facing, this can be reduced. So this is the most important, because even for us, we feel that considering one is aging, considering another which is a major morbidity, blindness, we have a lot to do in this area. So even with the vertical programs that are already being implemented through the ministry, and a lot of corporates, lot of social NGOs working in this area, there is still huge amount of work to be done. So in that sense, we hope that we'll be able to contribute to a certain extent to ensure that we'll be also addressing some key morbidity under ophthalmology. As we also see that the main causes of blindness are also the major, the cataract, the uncorrected refractive errors, glaucoma, diabetic retinopathy, age-related macular degeneration. So these are all very critical areas. We are aware of these things, and that is one of the reasons that we have tried to ensure that our packages are comprehensive and covers across all these key conditions. So overall, we have around 68 packages under the ophthalmology, with 4 newly added packages, which is currently not yet live, but will be live soon. So the new packages are the optic neuritis, glaucoma screening, which we have tried to keep it in 2 things, and the diabetic retinopathy packages, screening packages. So these were mainly introduced to ensure that the higher end packages are utilized much lesser. It will be more cost saving for the scheme also, because these untreated conditions will land up as major complications and will require more funding to treat those cases. So that was the background with which we have ensured that these are also available, so that we will be able to manage these conditions at an early stage, than allowing more morbidity and a lot of disability because of loss of vision and blindness that these complications may cause. So, just trying to list these packages. So there are already, the link is not opening. So we have a list of packages. So in case when there is any doubt, I can reopen the Excel and show it to you. So Our packages mainly cover all aspects of the health conditions. So when we look at the utilization pattern, so you might find that these schemes are being implemented at different levels, because some states have started implementing these newly. So what we feel is they do not have the history of the kind of schemes that were implemented in the southern states. So many of these states are also implementing this level of large scale schemes first time. So these we call them as greenfield states, whereas the more mature southern states and other states who had a good implementation of previously the RSBY and also the state specific schemes, we call them as brownfield states. So overall, this is the pattern in terms of the top utilization of these ophthalmic packages. And what we also see is the public and the private share. Private having a share of 81%, though they have 47% of the empaneled hospitals under them, whereas public hospitals still show a much lower utilization, though the number of hospitals empaneled for the ophthalmology services also are shown higher. So in that way, I feel one of the main reasons for accepting and reaching out to this audience is also that because these are certain lot of care is being taken by beneficiaries still in the private facilities. So we need to make sure that at least these services need to be provided under the scheme, so that they will not have much out-of-pocket expenditure for the beneficiaries, and the uptake of the scheme and will also be improved. So when we look at the common usage of packages, it is mainly the cataract, pterygium, capsulotomy, retinal detachment surgery, vitreoretinal surgery. These are our top 10 packages with, these contribute almost 90% of the overall utilization of the scheme. So in that sense, what we are looking at is these are some are not avoidable. For example, cataract and all is age related. Whereas if you go down, what we can see is the retinal detachment and vitreoretinal surgery and retinopathies. These are three which are actually forming 40,000 cases, which are something which is to some extent, it may be by providing early care, we might be able to reduce the complications. So we also had done a working paper on the utilization of the cataract management. And we, especially in the first year of implementation, we tried to look at and see how these uptake were there. So this is uploaded in our website. So a detailed paper is already available. So we have tried to include some of the states from which we were getting data at that point in time. So what we also looked at is main case being booked at that time also was cataract surgery. So the cataract burden is still not reducing. So there is a lot of imbalance in the distribution of the ophthalmologists, because many services are still available mostly in the urban areas. And the empaneled hospitals, if you look at the locations, are also more in terms of the district headquarters or in the taluk headquarters or in the urban areas. So what we are also looking to see is one second, I'm not able to see. Yeah. Okay. So what we also wanted to make sure is to review these cases and identify what are the changes required to be made at our end also, and see how we can reduce the impact of these morbidities within our beneficiaries. So as we move ahead, the one of the thing that we have also looked at is in our HPP 2022 revisions. Currently, we have increased the packages, total packages to 1949. So we have around 1,251 surgical packages, medical 696, and unspecified 2, wherein we have unspecified packages with cap of up to 1 lakh and another unspecified surgical packages with 1 to 5 lakh packages. And we have introduced palliative care as a new specialty, and we have expanded the scope of the interventional radiology specialty also, along with additional packages across the various specialties. So overall 365 new procedures have been added in HPP 2022. So overall we have now 1949. We've tried to unbundle some of the costs for high drugs and consumables from the bed day cost, so that we are able to add this as an additional add-on package for certain specific conditions, wherein earlier it was only available as a per day package under the medical category, so which was not possible to cover the cost of some of the high-end drugs and medications. So the second thing is we have also tried to make sure that some investigations are also unbundled. Since we are doing a pilot on the e-rupee aspect to see how we can address the out-of-pocket expenditure due to diagnostics before admission. So we are running this pilot currently in Chandigarh in PGI. So we might see how we can use that specific feature to cover some of the high-end diagnostics. Again, we have looked at the cross specialities and ensuring certain additional follow-up care packages and pre-anesthetic packages. And for implants, we have tried to make sure that we have a standard specifications mentioned, so that it should be either FDA, CE or DGCI approved implants in most of the high-end implants that we use. Some of the other thing what we have also done is for mental health packages, we have included certain evaluation packages, so that which needs more specific tests and psychometric analysis and additional counseling. So we have tried to use that. High-end procedures, we have bone marrow transplant and cochlear implant surgery. And we have ensured that this is a broad-based consultation. And we did have inputs from your IHOPE team also for the ophthalmology through the associations and other stakeholders. So, and we have tried to review the scheme utilization and ensure that we hope that the packages are more acceptable at a broader level. The COVID screening packages are still, still continue to be a part of our list. But it is state specific because the rates are as per the ICMR or the ministry and the relevant states. So all our cases, all our packages include outpatient consultations. Now we have, because of the COVID, we have also looked at the teleconsultation also. It's consultation irrespective of whether it is an OP consultation or a teleconsultation. Any kind of diagnostic workup that is 3 days prior, along with the cost of hospitalization, drugs, and other things. So specific high-end procedures have already shown. They are only available as per the mapped specialities and the packages under which they are allowed. What we have brought in this time is a differential pricing, because we used to always have this complaint. Why do we have to have the same rate across a tier 1 city and a tier 3 city? Right? Because people used to feel that the cost and the standards of living are much different thing. So what we have taken is a very unique approach. We have tried to do this differential pricing, not just with the tier of the city, but also looking at whether the packages or the services is a secondary package or a tertiary package. So tertiary package, especially in a much higher level facility and a teaching and a more advanced care is required. So what we have looked at is the kind of base price. Beyond that, the weightage that is given to a tertiary care packages also will differ based on the inputs that go into those services. So for tertiary packages, surgical packages, we have a 25%, and medical packages, we have adjusted it by 10%. Secondary packages, we have kept the base rate as the thing. Along with that, the tier 1, tier 2, tier 3 city will be there. So we have tried to keep the base rate for the tier 3 city. But for a tier 2 city, surgical packages, there is an increase of 17% and 25 and 15% for the medical packages, whereas tier 1 has an adjustment factor of 25% and a 15%. I wouldn't say this is an incentive, but this is an inherent adjustments that are made to the pricing of the procedures and the packages. And other ongoing incentives which are already there, especially for aspirational districts, for NABH and quality accreditation and PAS accreditation for public hospital, all those will continue to stay. But once this comes in, we will be will not have the specific adjustment for metro cities and for DNB and teaching, which is now being subsumed in a different format. So for example, if we say for a base price is 40,000, for a PTCA procedure in an X category, it will have procedure price both for tertiary, because it is a tertiary procedure and it is a tier 1 city, it will have a 25% adjustments for both the things. But this does not imply for implants. So the implant cost will be remain the same, whereas the procedure cost will be different. Whereas an if it is a Y category, the procedure price adjustment will be 17% and the tertiary procedure adjustments 25%. And for a Z category, it will be the adjustments only for the tertiary level procedure with no adjustment for the tier of the city, as it will be as per the base rate. So in this way, the pricing will now be has now been adjusted, and we will be implementing that in our HPP 2022. So along with this, as we are rolling out HPP 2022 and newer initiatives, what we've also tried to look at is since August 2020, when we launched the SDGs for the new for the packages. So we have been rolling out subsequently as and when these SDGs are being developed. We have ensured that currently we have covered all the packages under our scheme based on the kind of guidelines that are already available. So we have not come out with any new guidelines on our own, but we have tried to use the existing guidelines mainly with the aim to develop for us to how do we adopt and customize it, right? So we have tried to look at the ICMR, DHR guidelines, the national cancer guidelines, the state guidelines, ministry guidelines, globally accepted standard protocols, and then look at how we have customized it to ensure that this will aid in the processing of pre-authorization and claims, and also identify and help in preventing any fraud or abuse, and ensuring quality of care to the patient, and it will also act as a guiding tool for the treating doctors, the empaneled hospital providers, the ISAs and the TPAs who process these claims, the state health agencies who audit, and the medical auditors at different levels. So initially we started with the 53 ICMR released STWs. Then we looked at all the other national guidelines. Then for complete oncology, we have relied on the National Cancer Grid guidelines. We've looked at other state and MOHFW. So the process that we have followed is to ensure that these have a very strong review process. So we have co-opted the STW expert committee for each specialty from the ICMR. The DHR ICMR had set up the expert committees, which includes eminent experts for each specialty, both public, private, and from various reputed institutions. So we had co-opted them. So we used to draft the first, we used to use their clinical guidelines and make some adjustments and customizations for our scheme implementation, and had a full internal and expert review. And with the NHA approval, we used to integrate that and ensure that this is scaled up, and a lot of capacity building is also done. So overall, what we look at is in our SDGs, we have looked at it as a guidance document for processing our scheme. The introductory part, what is this guideline, for which packages it applies to, and what is the code, what is the price, and what are the minimum qualifications of the treating doctor, any specific empanelment criteria that is required, and a disclaimer on specific terms and condition, because this many a time, if clinical treating doctor will have a much larger role in the decision making. So we are not restricting his decision making. This is a much broader guideline. We hope that it will be useful in most of the cases, except in some exceptional cases. So that kind of a disclaimer we have tried to have it. And what we also look at is the guidelines for the clinical. What are the clinical pointers, the standard treatment workflow? We attach the links to the clinical guidelines and flow charts and other things as per the protocols that is available. And we also have a mandatory documents, because that will help them in uploading the for the pre-auth and the claims processing. So in part 2, we look at the time of pre-authorization, what are the things that are required, and part 3, we have the guidance for the document for the PPDs and the CPDs, so that they can review the cases and the claims. And part 3 is an IT check, so that we can have some of these questions which are more clinical, more technical, that are required to be. It's a self-check at the time of submission by the hospitals, and also at the time of approving the claims from the processing teams. So in some cases, we also have some checks for the medical auditors. So as we move ahead, and the kind of collaborations that we are building up, so we have looked at and we have now partnered with IHOPE for a study on understanding the outcomes of the kind of care that has been provided to the beneficiaries. So mainly looking at the vitrectomies and the diabetic retinopathy. So we're looking at more at a broader level on the kind of clinical characteristics of the patients, the kind of procedures that we are procedures that we want to review, and the kind of any readmissions, adverse effects, and the kind of costs and analysis. So to some extent, we will be working to analyze the claims data together and see how we can make some informed decisions and get some insights into better provision of care, and see what are the things that are required to improve the kind of ophthalmology services under the scheme. So, and the second thing we are also, we have collaborated to is also with IHOPE and NICE UK to understand how we can institutionalize the process of these SDG guidelines development, and how these processes need to be much more streamlined than ad hoc. Right now, we have tried to pick up many things from many places, but how can we make this as a much more refined process and work with specific organizations and improve these processes? So we hope to continue that collaborations with the for the better development of these SDGs. A few things and new initiatives. So we are looking at, we have created a health financing and technology assessment unit within our own division. So what we also like to see is any requests for new packages and new treatments, new drugs, new technologies. You can actually submit it through our portal. This will be a part of having a broader stakeholder request to understand the kind of how to make our packages comprehensive and cover more conditions. And we will, whatever suggestions we will receive, we will review it in detail, and we have a process to look at both the HTAs where the data is already available, or to request for new HTAs where we can actually get it done through our collaborators, and especially we do work with DHR HTA unit and other organizations where we can collaborate on this. Another thing, that new initiative we are looking at is also to move towards value-based care, so which is very important beyond a quantity, the scheme initial days, we were looking at how many people are benefiting from the scheme. Now, what we are trying to do a little bit more is to ensure that whether the scheme beneficiaries are getting quality care and how we can assess that, how we can incentivize a value-based care system. And I'm happy and thankful that we have received your inputs from IHOPE, and we will be reviewing it and making sure that we'll see how to utilize those suggestions. So that's it from me, and I'm sure we can open up for further discussions.
Yeah, thank you so much, Dr. Sudha Chandrashekar, for that wonderful presentation. Actually, quite a few insights, and also it has generated a lot of questions in the chat box, as you can see. But before we move on to the questions, I would like to welcome Mr. Hugh McGuire from NICE International, who has joined us in this meeting. He's a senior scientific advisor. And as you all know, NICE advises NHS on various aspects of healthcare. Dr. Sudha, since this is an audience for ophthalmology, just wanted to know from you which package among all the interventions are reimbursed the highest. I believe ophthalmology scores very high. Is that true?
Yes, I think if you look at the scheme utilization, it is still one of the top procedures. Cataract surgeries and other conditions, ophthalmology is one of the top procedures being utilized under this scheme. I think dialysis is not far behind. I think dialysis is also one of the mostly utilized procedures. So in that sense, both actually indicate that there is a huge burden of communicable, non-communicable diseases, which is leading to all these end-stage complications. So that is something which prompts us to relook and make some changes in our benefit packages by introducing some of the preventable conditions, or how do we screen them early and get them to early care.
Yeah, thanks. So I think just to re-emphasize what Dr. Sudha Chandrashekar said, cataract probably is usually among the top three, sometimes the topmost reimbursements among all the packages which are there, oncology, OBGYN. So cataract utilization under this scheme is very, very high. We'll go on to some chat box questions. We'll go in sequence. There is a question on, will differential pricing affect adverse selection and moral hazard? Then it will be a challenge for the success of the scheme. So the differential pricing which she's mentioning here, I believe, is on the different tier cities. Is that right, Varsha? You can unmute. I don't know if you can unmute, but I believe it's on the differential pricing in different tier cities.
Yes, it is the different tier cities as per the 7th Pay Commission. So we have around 8 cities with tier 1 and around 96 cities with the tier 2, and rest are all tier 3.
Yeah. So there is a question on retina, again, the utilization of diabetic retinopathy and AMD with intraveteral injections. Now, intraveteral injections is not covered at this point of time, although I believe NHA is looking into it. Any insights, Dr. Sudha? It's something which a lot of practitioners are asking for. So what exactly is the status, and how do you want to roll it out, the intraveteral injections?
Basically, it is still an outpatient procedure. So we have not yet, because mostly we are trying to keep the procedures mostly for in hospitalization, or at least a kind of a daycare procedures. Whereas intraveteral injections, there are so many options available, and the kind of, for implementation processes will be quite difficult.
Okay, yeah, so I think intraveteral injection is something which probably is one of the most commonly used procedures for a lot of retinal diseases. But at some point of time, we would, all retina surgeons would definitely like to see getting covered, because a lot of retinal diseases can be managed with these injections. So
So I think that is one of the things we are looking for more guidance on how this can be done. So maybe we will,
yeah,
open up for feedback whenever you can submit it. What's
sure.
the best way to do it? Because right now it's very difficult, because whether it was administered, not administered, how do we check that? And because the costs are involved, and the monitoring will be very difficult. It will be happening at a clinic level. So how do we restrict its use?
Yeah, so I think we certainly would be looking into it, and we'll get back to you with the overall thought process with the broad stakeholdership, and maybe come up with some solution for that. And also, I was wondering, just as an add-on, since we are looking at universal health coverage, we are looking at preventive care as well, and the number one cause of visual impairment is actually refractive errors. So people need spectacles, and now we also know among even kids the prevalence of refractive errors is increasing. Has there been any thought given to, let's say, reimbursing glasses? I mean, it sounds very different, maybe a difficult question, but it's the most common cause of vision impairment actually. But it's not an easy thing to implement probably. Any thoughts on that, Dr. Sudha?
I think we did discuss that, but see, that doesn't lead to catastrophic health expenditure. So we have a certain minimum threshold of what can be included and what cannot be included. So we all know that there are so many things on an OPD basis that needs to be considered, kind of, simple aids that we can be given, like hearing aids, or it can be for any other condition. So there are multiple things that can be that is required for the healthcare. But PMJAY cannot be an answer for everything. So what we have to look at is what is the scope of our scheme, how how much we can expand, what are our boundaries. I think in that sense we should limit ourselves. And I think there is the Ayushman Bharat wellness centers, the kind of public health facilities who are providing a lot of other services. So I think they can take up this, and you might see how to improve uptake through those other avenues that are already available. So I think we shouldn't be looking too much on PMJY for everything.
Yeah, I think that you have brought a lot of clarity in the thought process and how PMJ works, and how we have other avenues to look at for all these problems. We have a question on glaucoma and DR screening by Divya Rao, and she's asking whether if the screening were to be done at a physician level or at an ophthalmologist, is there a difference in the cost reimbursed, or is it the same? So I believe in the packages it's the same, it's not different, and it is at 1,000 rupees, if I'm correct, the screening. By it includes both visual acuity, refraction, as well as fundus photography, and OCT can be reimbursed under that.
So it will be the same rate, so there is no difference.
Yeah, good. So there is another question by Kriti, who is an IHOPE member. She has a question on what conditions are covered under unspecified packages, and how is it decided what category will go under unspecified packages?
So these unspecified or unspecified surgical packages, these are not packages for medicines. So that needs to be clear. If particular surgery, because we know that, these are the listed common surgeries that we are covering, but there is something that is done differently, or a particular thing which is, it's mainly a surgical treatment which is unspecified is covered. The guidelines are very clear. There is no costly medicines or anything like that can be booked under these packages. So this is a specific outlet for covering something which is a surgical procedure. No diagnostics, no drugs.
Okay. Yeah, thank you so much. I hope that answers Kriti's query. And there is another question by Samir Gokhale, who is a health economist. He has raised this question: will the results of the cost effectiveness analysis be available under standard treatment guidelines?
I think we are looking at that. So if we do some joint analysis on those things, cost effectiveness, whatever we do, we will be publishing it, putting it up for the public domain. So definitely it will be available in the public domain itself. So specifically, I'm not sure, we are not looking at ourselves doing the cost effectiveness. So when we are reviewing some treatments or anything, we will be looking at a more what I can say, an evidence synthesis, right? So if we have other approaches to treatment, we will try to look at an evidence synthesis than actually performing a CEA analysis, because that is more time consuming, and our mandate is not to be a economic appraisal agency. So we were users of the evidence. So we are supposed to make ourselves informed users. So to some extent, we will use the available evidence and review it and see how we can look at it under the thing. If IHOPE is doing something and we want to collaborate with them on any kind of analysis, definitely yes, we can look at that as a separate proposal and review that.
Yeah, so in this context, Dr. Sudha, I just want to, maybe you can elaborate a little bit on the HEFTA, Health Financing Technology Assessment, which is a new arm which the NHA is looking at. So how and what would be the role of health financing technology in your decision making?
Yeah. So here we are looking at 3-4 aspects, because there are a lot of new requests that come in and new available technologies, and this industry, the stakeholders, they all keep sharing with us. So we have some unit to review all the requests, because the problem is when we are doing an implementation of the scheme at an operational level, this part of the work gets left out, because we keep getting representation, but there's nobody who will work on it, right? So this unit will actually look at it, review the kind of request, prioritize the requests, because all the requests need not be gone in. No need to go in depth in many of the requests. So we can actually see what are the kind of requests that are coming in. How do we prioritize that? And whether it is something that is relevant to our scheme implementation, or it is something relevant to a ministry, we can try and sort it out, and we act like a screening agent there to make sure that it goes to the right place. Because people many a time don't know where to submit the request, so they do keep submitting at different levels. So we'll be doing that. And another function that we are looking at is to look at how do we have a strategic purchasing function, because we have a huge payment across towards implants, whether it's cardiac implants, orthopedic implants, or ophthalmology implants. So we do spend a lot of money, and both on implants and drugs. If you look at our onco packages, are mostly the medical oncology, or a lot of high-end drugs are there. There are many packages for cancer drugs that we have. So we are also looking at how do we make a much more strategic purchasing process, so that we can, being a large buyer or large payer, can we do some collective bargaining? And how can we establish that process across our own scheme, to see if we can ensure providing these kind of implants and other thing at a much lower level, lower cost to our empaneled hospitals. So we are looking to guide the states so that they can do it at the state level also. And whether can we do it for some of the cases at the national level, and do some kind of rate contracts on behalf of the state, so that states can actually place their orders. So a lot of things that we are trying to do is to improve the operational implementation of the scheme also. The third thing this HEFTA unit is looking at is also how do we pay the providers. Currently, we have a bundled payment system, and what we are moving towards is a diagnostic diagnosis related group kind of a payment, which is the advanced kind of payment system. As we move towards universal health coverage, and developed economies are already moving into it, because where the clinical diagnosis and the kind of severity, the comorbidity, the complications, everything gets accounted for. Currently, we are paying a flat rate to any kind of patient. So we don't pay separately for complications. We don't pay anything additional for a severe case or any kind of comorbidities that the patient may have. But as we move, we are doing this pilot in 5 states now. So we will be looking at how this gets operationalized and the kind of feedback that we will receive. And that is something we are making sure that that will feed into the decision making, right? So all these small experiments that we are doing will be under this broader unit, so that we have dedicated team who have those requisite qualifications, who will be working with us on these aspects. Otherwise, if we don't have a formal division, what happens is we are more operational in nature, right? So we want to make sure that we have the policy team, the kind of implementation team, and also somebody who's thinking of innovating and seeing how can we do things better.
So just as an add-on, I think when you were mentioning about pricing, one is you can leverage as a single large buyer, and you can definitely get deep discounts on that. That is one way. Also, if there is any thought on including quality of life differences, and using that as a measure to see if an intervention is cost effective or not. So is there any threshold at which you will approve if there is any analysis based on quality? So is there any thought process going on? Because there is a question on health related quality of life by Aparna Mittal in the next one, but slightly related question on quality of life.
Yeah, I think as you might have seen in our value-based care assessments, we are trying to bring in the quality of life aspect also in the kind of interventions and the care that we are providing. So definitely that is something that we aspire to move ahead, so that we incentivize interventions and care provided, which will have a much better outcomes. Not to say that, within the kind of boundaries, because we do understand the complexities of the medical care. So even all going well, many times the outcomes may not be the best. So we need to ensure that the kind of processes that we use to measure these things, and the kind of threshold that we do, I think that is something that we are working as part of the DHR. To say, I think that ministry or at the higher level has to set those standards for thresholds for what is the quality of life we'll be willing, how much will be willing to pay for one additional colleague, right? So in US, they might have a higher threshold up to, unless up to the cost of 1,50,000 we'll be ready to pay. But the willingness to pay threshold for India to accept is at least 3 times the GDP, around 4,500 rupees per quali. So we have to make sure that whether these quali, what we will be looking at is as per our context. And for that, we look forward to the kind of thresholds being set by the DHR team and the team working on the cost effectiveness threshold.
Yeah, so there is a question on cataract surgery and its reimbursement in the Ayushman Bharat package. I'll put it in a different way. A lot of practitioners, feel that the cataract surgery reimbursement rates are extremely low. How does the NHA, look at whenever they get inputs on price revisions, and I know a lot of times you will be getting huge number of requests from everyone almost to increase the reimbursement in their particular specialty. But how do you work it out, and what all factors do you look at?
Okay, basically we look at whether those packages and those services can be provided by public hospitals. So we try to keep for the services that can be provided at the public hospital, we try to keep the rates much lower, because we don't want to bypass the public system and, allow a very open field for the private, for accessing the private care, right? So that is the reason that cataract is still something that most of the public hospitals can provide. So that is the reason we have kept the rates still lower.
Yeah.
And other aspects that we look at is also the costing. So we now have a good costing database that is being built up for the Indian setting. So we are using those cost evidence as and when we receive it, and reviewing the thing. And the third option we do is a lot of consultation with the experts in making sure that the kind of our components of the scheme are covered, so that we can make sure that we are not looking at a completely cost to cost, trying to make sure that we are able to give a reasonable price, acceptable price to most of the hospitals. And also we see the same surgery, we can say that if it is done in a tertiary care setting. So we are also looking at what are the procedures which can be done at a secondary care setting. That is why we have adjusted it for secondary. And an appendicectomy done in Max or Fortis will definitely cost higher, right? But it is not a procedure that needs to be done at that level of care in terms of such a higher level of facility. So what we are looking at is for tertiary care packages, we try to keep it much more attractive, because we are aware that the capacity of public hospitals is limited for tertiary care. But for the procedures which can be managed at the secondary level, we try, and where there is a huge availability of services. If you look at whether it is it can be done in nursing homes or or in a smaller level hospitals, also we ensure that it has to be kept at a much kind of a reasonable level. So we identify some of the things, and sometimes complex surgeries we don't have any option, and it is the volumes. Volumes are also very critical, because at high volumes, if it is a very high volume case or a high volume procedures, then we also want to make sure that it is financially viable. Whereas in a complex case, which happens for very few, the kind of incidence is so low, even if you keep it at a higher level, because you need that amount of infrastructure and the kind of skill that is required, the volume will not be too high and the financial burden will not be much, right? So we take into a lot of factors and make sure that a reasonable kind of and finally the decision is also implementation at the state level. National level, we might set any prices. It doesn't mean that if you on the ground at the hospital level, what you see at the states is the same rate as the national level, because state may iterate it further. So we do not say that they cannot do it, because we have given them flexibility. It is state is also contributing a huge 40% of their resources, so they have a say in that. So they will be the final one, whether they want to change the rates, whether they want to reserve the packages. So they will have a lot of say in it. So that is one of the reasons there might be some variation in the kind of rates that you see in different states, and the kind of policies also, there might be some differences.
Yeah, thank you so much for that elaborate answer, Dr. Sudha. I'm afraid we are running out of time. I would probably take one question from the audience before I ask Dr. GVS Murthy and also Hugh McGuire to give in their final comments. But I would request Arnaz to note down the unanswered questions that we have in the chat box. Maybe we can compile, consolidate some of them, and have Dr. Sudha look at those questions. Where possible, we'll give the answer. So there is one question by Sushant Anand. We are talking about universal health coverage, and I'm sure when we talk about universal health, at some point of time, we should be covering everyone, irrespective of their socioeconomic status as well. Currently, it's the bottom 40%, which is being covered. So the question is, okay, if you want to expand it, are you looking into the middle income group as well at some point of time? So are there any thoughts, Dr. Sudha?
Of course, I think our main objective of NHA is to also support reaching that goal, SDG 3 goal of UHC, right? So we might be doing it in different ways. To start with, we have started with the bottom 40%. Some states are doing that additional coverage. But as part of the NHA's mandate, right now we don't have that to cover the missing middle. But if states are covering that, we are offering them the IT systems and the processes, the guidelines. Definitely we will be supporting them at other thing. And there are some thoughts on some pilots being done. The Niti Aayog has come up with a concept note on how do we cover the missing middle. So we are engaging with Niti Aayog and providing technical guidance and the participation in those brainstorming discussions on how we can do it. So once there is a overall mandate that we receive from the cabinet or from the ministry, then definitely it is not something that we will we will resist. It is something that we are also looking forward to. Hope that maybe we hope the next 2024 elections may be fought on missing middle.
Wow, that's a very promising note that you are mentioning, that yeah, you are looking at expanding it further. Certainly the middle class group certainly deserves some more help as such from the government too. Now, I would like to ask Dr. G.V.S. Murthy and then Hugh McGuire if they have any remarks or any comments before we conclude this.
Thank you, Dr. Raja. Unfortunately, you can't see my face, so you can't give me cosmetic surgery costs because the host doesn't allow us to be seen. Dr. Sudha, that was a wonderful presentation, and it actually clarifies a lot of points that people would have in their minds as to how we go forward when we advise patients. So I think that is a great presentation. I just had 3 comments, and I thought you could perhaps help us in looking at that. The first is, like you mentioned, when it comes to packages, you have your technical advisory groups or expert groups whom you consult. So one layer, I was just thinking, if it's possible, is to have institutions like, say, LV Prasad or Aravind or RP Center, who are centers of excellence, and WHO centers for prevention of blindness. Now, if you look at those being part of the advisory panel as an institution supporting you, because all these institutions have from primary to super specialty care. So they can give you a very good understanding of what the pricing is at different levels. So if something like that as an institutional advisory mechanism, so they could actually provide a lot of details. So that was one thing I had. The second point, now what you mentioned is right in terms of when you look at cataract and you say, okay, cataract can be done at a secondary center, but there within the within the cataract space also, thank you Arnaz for making me visible now. So within the cataract space, you also have different procedures. Now, if somebody has to get let's say a phaco surgery, now that may not be available at many of the secondary hospitals, but then it would cost more. So we also need to look at, okay, if there is going to be a situation like that where we recommend a phaco, could we look at some sort of a differential bridging that, okay, I look at 2,000 rupees for cataract in a secondary center, just like you have your city packages. So if I'm going to an institution which is going to cost me more, can we look at some sort of a leverage there? The third point, and I think I would be speaking for a lot of people on that, when we look at our legislators, our parliamentarians, they are public people. They're elected by the people, and therefore whatever our procedures offered to them, I think it makes sense to have that as the template when we are looking at a scheme which is public funded, because their care is also public funded. I know it's a very difficult thing, but I think, you know, if you want to drive out inequities, we have to start right from the top, that there should be no differentials on some people getting more than the others from the same public system. Like I said, it's difficult. I don't want you to answer that, Dr. Sudha, but I think in the discussions, this is important, that if we have to get rid of inequities, then we have to take some stellar steps which will showcase that we are trying to break down those inequities. So these were the 3 points, but excellent presentation, Dr. Sudha.
So I will answer that starting from the third one. So instead of trying to say that, you know, whatever inefficiencies is already happening in that scheme.
No, inequities, not
I know
inequities.
it is inequities, but it is inequities plus inefficiencies. So what we have also looked at is, instead of we raising the inefficiencies to some extent to meet them, what we were trying to do is that they should get the same thing as what
Absolutely.
a PMJAY scheme is doing. So we
Absolutely.
put up that concept note and said that we have to standardize the packages across all the schemes based on the medical and the clinical procedure required. The hotelier services plus you can add it for a, you know, semi-private ward, private ward. That is something that you can do additional. But to some extent, we were trying to push that and make sure that there is a standardization of the medical care across all people. And that is something we started off with. And as a baby step, what we have tried to do is to integrate their scheme with our PMJAY system. At least now we know what is happening there, because that was a black box before. So now we understand it from within the system of how things are happening there and what are the areas for improvement. So definitely we will be working slowly on it. So we have been taking speaking about it at every forum that we can. And there has been some traction at the highest levels also, that, you know, at the policy space also, that even across the state schemes, across the state government employee schemes, we are trying to work towards that also. We have been supporting a lot of state governments also. How can they do the packages for their employees? So it should be PMJAY plus. You know, you cannot have something very different for a government servant than a person who is doing. So we already have a very standardized and a very, you know, evidence-based system of how we are trying to build these packages. So we are trying to make sure that this plus something you want to offer to the state government employees, because they are giving a contribution, right? So we are not saying that they should not get some additional benefit of their contribution, but we have to work on that in a very different way. But we have to have some kind of a standardized rate for a procedures at different settings. So that was one thing. The second thing you wanted to also look at was the bridging, right? So the bridging was what we tried to do by giving tertiary care packages as a procedures for an additional percentage, right? So that bridging happens that in case it is a teaching institutions, in case it is a, so the kind of cases that come to them itself will be little different. So we are, and that we also will be adjusting it through a diagnosis related group, wherein the complicated cases and the processes are going to get something extra, right? So the kind of facilities that they might move even for a secondary procedure may also depend on an 80-year-old or with a high complication going in for a certain surgery. So all that gets captured in the DRG pilot. So as we learn a little bit more, this is already being done across the world. So there's nothing new about it. We are already, at least the policy in principle approval we have to do this pilot and review how we can make these adjustments to these pricing based on the diagnosis and complexities of the care that is being provided. So that bridging, we'll be doing it in an adjustment to the provider payment systems. The third thing was institutions. Yes, we are, I think we did take feedbacks, though we could not take all the recommendations that came from IHOPE team. They were consulted. So not only them, there were many other associations hospital association, IMAs, wherever we could get a good participation to our discussions. We had separate sessions with many things. And since we have empaneled hospitals and clinicians being a part of our scheme implementation, as and when they give their requests, all those things we have separate sessions with them. So we do a lot of broad-based consultation in different ways. So that is something that we have started up. And this time we have actually introduced the patient groups. Normally at these kind of government institutions, you wouldn't expect that people would be, talking to these kind of groups. But definitely this is a first time effort we have tried to do. We have interacted with patient groups of certain specific things for rare diseases, for rehabilitation, for palliative care, for cancer. So we have tried to look at, this has been a more learning experience for us also, how valuable their insights could also be. So we are trying to institutionalize such processes. It will take some time because these are some radical reforms, right? So governments, the kind of environment we work has been moving ahead in a particular way. So when we try to kind of say that, okay, these are the kind of minor changes that we need to do. So it will take some time, but we are taking those initiatives and they are getting good results of that.
That's excellent. Just to formalize that, in terms of the institutions, maybe you could have 25 institutions for different specialties who actually become the institutional think tanks, and they can in turn gather data from the others and feed it to you so that it becomes more systematic in a formal manner. But excellent, Dr. Sudha, thank you so much. Back to you, Dr. Raja.
Once again, thanks, Dr. Sudha. But again, thank you, Dr. Murthy, for those very important questions. He brought in and not just excellence, but equity along with the ambit of universal coverage. So very important. So and I could see that we are working towards that. NHA is working towards the it should be equitable wherever we are looking at excellence too. So before we wind up, I would like to request Hugh to please unmute and even switch on his video if possible, and give his comment. Maybe start off with how NICE International is looking to partner with other countries, and how has the experience been so far for NICE International working with India and IHOPE. Over to you, Hugh.
Yeah, thank you very much, Dr. Raja, for inviting me to join the session, and sorry I missed the start. Dr. Sudha was an excellent presentation and very informative for me, and giving me some insights into the context in which you are working in India, and which we're working with IHOPE in sort of developing guidelines. Yeah, we're in collaboration with IHOPE to help develop clinical guidelines in the field of ophthalmology and also public health. And we've been giving some advice over the last few months and having some knowledge transfer sessions, which have been quite informative. And we're getting ready now for the next set of sessions, which are starting on August the 2nd. But it was very, very interesting to hear your talk, Dr. Sudha, and especially how you plan to use guidelines as a means of driving forward improvements in the service. So I think it's quite informative for us. Thank you.
Thank you, Hugh. And once again, in the interest of time, I think we have to conclude now. And thank you so much, Dr. Sudha, for the excellent presentation and all the clarity with which you spoke for all the questions which the audience had. I think it added much more value than just the presentation which you had. But I'm sure people still have many more questions than they had typed in the chat box, but even the questions which we have not been able to answer. But I have requested Arnas to compile those questions, and we'll certainly try to answer as many of them as possible. So once again, thank you all very much for participating in this webinar, and have a good evening to you all. Thank you.
Thank you.
Thank you, Dr. Sudha. Thank you.